Good morning or good afternoon to all of you out there, wherever you are. My name is Cindy Rote, and I am your hostess today for the NCIHC On the Road webinar on a topic of great interest to everyone in the country, which are the new regulations that have come from the Department of Social and Health Services on Section 1557 of the Affordable Care Act. Again, my name is Cindy Rote. I am the Vice President of the National Council on, we switched boards. I'm just on the board now of the National Council of Interpreting in Healthcare, but very honored to be the moderator for today's panel. We have three incredible panelists sitting here with us today from various parts of the country. I am so honored to introduce these people and to bring them to you. First of all, I'd like to introduce Mara Yudelman, who is my hero. Can I just say that, Mara? We'll just introduce you as my hero. Mara is the Managing Director for the Federal Advocacy at the National Health Law Program's Washington, D.C. offices. She's been there since 2000, and I want to say, forget the bio, Mara. I'm just going to say, I don't think there is anybody in this country who has done more for language access from a legal point of view than Mara. She is the one who advocates for these issues in legislation, in regulations, and much of what we have of legal support for this is because of the work that Mara and the folks at the National Health Law Program have done. So she coordinates the federal legislative and administrative work there, leading the organization's efforts at protecting and expanding access to and quality of healthcare for low-income and underserved populations. She also co-chairs the Leadership Conference on Civil and Human Rights Healthcare Task Force and its policy and enforcement committees. And you all may know that Mara is obviously a lawyer, but we won't hold that against her. She's one of the good ones, okay? She's the good lawyer, right? She has completed a teaching fellowship at Georgetown University's Law Center's Federal Legislation Clinic, spent 2 years litigating for the Administration for Children's Services in New York City, and her JD is from Boston University School of Law with a BA from Tufts University. She also I didn't know this, Mara, founded AWARE, actively working for acquaintance rape education, an interactive educational program on acquaintance rape. So there's Mara Yudelman. Everybody go to your comments and clap for Mara. Ooh. Our the second person to join us at our little coffee clutch today is Sean Norris, who I have been told is the nicest person in the country. That you should put that on your business card there, Sean. Sean is a healthcare language access leader. He has had multiple key positions, including president of the Florida Registry for the Interpreters for the Deaf, commissioner for the Certification Commission for Healthcare Interpreters. He, in his background, has been enriched by his deaf parents, and he is an active advocate for the deaf community. He's spent over a decade in the interpreting field, mentoring emerging interpreters and founding a local agency to ensure language access in Jacksonville, Florida. Currently, he's developing Hello Interpreters, an online community for interpreters and translators. He is one of the few practitioners who have held ADA coordinator, Section 1557 coordinator, and interpreter services coordinator roles concurrently in a hospital system. So Sean knows whereof he will be speaking today. Absolutely. Our third panelist today is Joanne Cox. We are very honored to have you, Joanne. Joanne is the Senior Vice President and Chief Experience Officer at Yuma Regional Medical Center. She and her team work across every department in the organization to foster a culture of service excellence while enhancing patient and family relations. With 30 years of experience in healthcare, Joanne has focused explicitly on the patient experience since 2015. Previously, she served as a patient experience coach, held leadership positions as the National Director and National Senior Director of Patient Experience with Steward Healthcare based in Dallas. During her tenure, she designed and implemented programs to improve culture and best practices for patient experience. Recently, she joined Yuma Regional Medical Center in 2023 as their first Chief Experience Officer. In her ongoing work with frontline staff, hospital leaders, and providers, she nurtures outstanding care at every touch point, from scheduling to discharge to follow-up care in both the inpatient and ambulatory areas. She has a BA in English from Skidmore in Saratoga Springs, New York, and received a Certified Patient Experience Professional designation from the Patient Experience Institute, which is an affiliate of the Barrel Institute. Joanne, we are so honored to have you here. It's wonderful to get folks from the C-suite that are actually willing to come and talk to us about these issues. So we're gonna, usually these on the road presentations are really just kind of conversations between experts. However, today we're going to take a little bit of a diversion and have Mara give a short presentation to just orient us about these newly released regulations. What is in there? What is new? What does it mean? And who does it apply to? So Mara, I'm going to turn this over to you right now, and you can help us understand what is coming at us here.
Thank you. And thank you to NCIHC for sponsoring the series, and in particular today's webinar. And also a huge shout out to our moderator, who doesn't get enough credit either. I really appreciate your kind words, Cindy, but seriously, the impact that you have had on the interpreting field and world from many different hats over the many years that I have known you, dear, you are one of my sheroes as well. So the love goes both ways, and maybe all around. And I love seeing everyone saying hello. All right, I'm going to try to share my screen and hope that this works, because sometimes I mess up and do the wrong one. I think I need to do this screen and then hit from beginning, and someone will hopefully tell me that they actually are now seeing.
Yes, we can.
Woohoo!
You did
Years
it.
of doing Zoom, we're getting good at it. Okay, good afternoon, everyone. Also want to give a shout out to our sign language interpreters. Thank you so much for being with us. And I usually warn folks in advance that, I have 3 strikes against me, which is 1, I'm a lawyer and I live and work inside the Beltway. 2, I'm a New Yorker and I talk fast. So I'm going to try to be good for the interpreters, but please stop me if I go too fast. I forgot what my 3rd strike is, but we'll leave it at that for today. So maybe it's because I'm a lawyer and I speak fast. Anyway, whatever. Okay. If you're not familiar with the National Health Law Program or NHELP, I have to do my 2 cents here. We're a national nonprofit organization. We focus on increasing access and quality of care for low-income and underserved individuals. We have, and I'll show you at the end, a resource page, which lots of stuff on language access and Section 1557, so you'll see that. I titled my presentation "Third Time's the Charm" because we've had a lot of regulations implementing Section 1557. For those of you who aren't as familiar, Section 1557 refers to a section in the Affordable Care Act. Some people call it the Healthcare Rights Law. We tend to just call it, because we're lawyers, Section 1557. It's a broad non-discrimination provision. So it not only reinforces requirements and expectations related to language access, and we get to language access from prior civil rights law that says if you take federal funds, this is Title VI for those of you who know, if you take federal funds, you can't discriminate on the basis of race, ethnicity, and national origin. Language can be a proxy for national origin, according to the Supreme Court and the Department of Health and Human Services. So that's how we've gotten there. Section 1557 is not just about language access or preventing race discrimination. It also prohibits discrimination on the basis of age and disability. And for the first time, it also prohibits discrimination in healthcare on the basis of sex. You may have thought you were protected from sex discrimination before 2010, but actually you were not in the healthcare arena. Also, an important aspect is these final regulations recognize intersectionality, that someone may come who's a person of color, who is limited English proficient, and a woman, and they may face discrimination based on multiple aspects of those factors. So Section 1557 covers all of that and gives everyone the same rights and relief based on intersectional discrimination as well. So I'm not going to provide too much background, but I want to make sure we are doing some level setting. So if you're familiar with Title VI from the Civil Rights Act of 1964, Section 1557 builds on that. So anyone who takes federal financial assistance is subject to both of these laws. So that includes your state, county, and local agencies, your Medicaid agencies, your public health departments. It includes any healthcare entity taking federal funds, hospitals, clinics, clinicians' offices, but also refugee resettlement agencies, nursing homes, mental health centers. In the healthcare arena, almost everyone is taking federal financial assistance in some way, shape, or form. Maybe not the concierge medicine practices we see cropping up, but for the most part, hospitals are nursing homes, assisted living, et cetera. Section 1557 also goes a little bit beyond federal financial assistance to specifically cover federally administered programs. So that includes Medicare, as well as the federally facilitated marketplace, or healthcare.gov. And it also specifically applies to entities created under the Affordable Care Act. So this includes state marketplaces and all of those, like we call them qualified health plans, but all those insurers who offer health plans through marketplaces, they're covered as well. In terms of its application to health insurance companies, these new regulations that were just issued say, once federal dollars touch an entity, the entire entity is subject to compliance with Section 1557. So let's say we have a big insurance company and it offers both Medicaid managed care plans or a marketplace plan, and then also some private plans for employers. Once it takes dollars from Medicaid or the marketplace, everything that health insurance company does is going to be subject to 1557. So this also means it will apply to, again, if there's federal funding going to it, third-party administrators, pharmacy benefit managers, some other types of insurance. Okay, so the law itself, Section 1557, was signed into law by President Obama in 2010. The law has not changed in the last 14 years. What we've seen change are the regulations that sort of explain what this law means, right? So if you look at the law in the Affordable Care Act, it's 3 paragraphs. It says, don't discriminate, and don't discriminate on these bases. What regulations do is put a little bit more meat on the bones. So the ones that we saw released last week, I'm going to first go through some of the main changes and then walk you through the language access provision specifically. So some of the main changes, if you've been following and you've looked at prior versions of these regulations, there's an explicit definition section. It includes the definitions of a number of language access terms, like a qualified interpreter for a person with limited English proficiency, a qualified translator. There's new recognitions of relay interpreters, a new recognition that a companion may have limited English proficiency and also need language assistance services. There's a requirement for a notice of availability. I'll explain that soon. There's also specific requirements that these covered entities, those that receive federal financial assistance, have to have written policies and procedures, a coordinator, grievance procedures, and train their staff. One of the new things, and this is one I've been working on in my entire 24 years almost at the National Health Law Program, is a recognition, and this is a change of interpretation from this administration, that Section 1557 and Title VI apply to Medicare Part B. Medicare Part B are the outpatient services covered by Medicare. So this is a new interpretation. We also think it's important because it now means that all parts of Medicare are subject to Section 1557, and Title VI, as well as the other civil rights laws mentioned in Section 1557. Okay, let's go through some of the general requirements. And again, because this law is broad and it applies to all forms of discrimination, we'll start general, then we'll get more specific as to language access. So covered entities, again, those subject to 1557, the ones who take federal financial assistance, a federally administered health program or activity, or an entity created under Title I of the Affordable Care Act. They have to develop specific policies and procedures, recognizing that they're not going to discriminate and how they're going to provide assistance, ensure they don't discriminate, and how they're going to assist individuals with limited English proficiency and individuals with disabilities. They have to disseminate a specific notice of non-discrimination and a separate notice of availability of language assistance services and auxiliary aids and services. This is a little bit different than what we've seen previously. Some of you who've been following this may know about taglines. There was a requirement in the first round of 1557 regulations under President Obama that said you needed like a one-sentence tagline, something similar to like, if you don't understand this document, call this number, you can get assistance in your language. These rules go a little bit beyond that. It's not just about the availability of language services, but it's also about providing assistance to individuals with disabilities who may need other types of communication assistance. An auxiliary aid and service, it could be a sign language interpreter, a transliterator, communication boards, other things like that. All of these entities also have to designate a Section 1557 coordinator. This is for entities with 15 or more employees, and Sean's going to talk a little bit more about that. They have to develop grievance procedures if they have 15 or more employees, and they have to train their relevant staff. Okay, let's get into a little bit of the specifics of language assistance services. Okay, first, timely and free of charge. You can't ask a limited English proficient individual to bring their own interpreter. You can't delay their services, like say, come back next Wednesday when our interpreter is going to be available. They basically have to provide meaningful access for limited English proficient individuals, similar to what's done for English-speaking individuals. There's a definition, well, multiple definitions actually, of qualified interpreters for people with limited English proficiency, qualified translators, qualified bi or multilingual staff, and qualified interpreters for individuals with disabilities. One of the changes that at least we at the National Health Law Program appreciated seeing in this set of final rules is sort of parallel definitions for qualified interpreter for individuals with limited English proficiency and qualified interpreters for individuals with disabilities. So there's sort of 3 steps that go through it, and we think it's important to recognize that those same qualifications should apply whether you're a sign language interpreter or a foreign language interpreter or a relay interpreter. As I mentioned earlier, there's also an explicit recognition that some situations may require the use of relay interpreters, and so that's recognized in the definition. And as I also mentioned, sometimes, let's say the patient might be proficient in English, but the person accompanying them as an advocate or a resource or a support person is limited English proficient. That companion can also get language services or communication services. This final rule also prohibits the use of non-qualified interpreters except in emergencies. If there's like an imminent threat, this applies both to adults and minors. If a limited English proficient requests, not in an emergency, but in a regular situation, using someone who's coming with them, and the accompanying adult agrees, that person can be an interpreter if reliance on that person is appropriate. And maybe we can discuss this in the conversation about how to look at that. Okay, so let's go a little bit more into this notice of availability of language assistance services. It has to be provided in English in the top 15 languages in the state and alternative formats for individuals with disabilities. It has to be provided annually and upon request, unless an individual opts out. Has to be on websites and in prominent physical locations in a minimum font size, and this is 20 points, a decent font size. And it also has to accompany the general notice of non-discrimination, as well as a variety of electronic and written documents. So this is where someone who's limited English proficient should get some information in their language about how to request language services or for person with disability communication services. There's also explicit requirements for audio and video interpreting. Again, these were reinstated from prior regulations. So recognizing that if you're going to use an audio or a video interpreting service, it must be high quality, it must be sufficient so you're not getting choppy, blurry, or grainy images, include an image large enough to display the interpreter's face and the participating person's face. The audio must be clear. And this last bullet's important. You have to train those who are using the technology. It's not enough to just say, oh, great, we have this system set up and nobody knows how to use it and it stays locked in a closet. Staff must be trained how to access it. Another specific provision, which we're really happy to see and supported in this final regulation, is a recognition that more entities are starting to try to use automated machine translation. There are commercial services, one big search engine, which I will not name specifically, or I don't know, maybe I'm allowed to, but whether you call, I'll just name it, whether you call it Google Translate or there's other systems out there, sometimes you see an entity's website and they have this little widget on the top that says translate, and they say it'll translate into any language you want. Well, there's a recognition that those translations are not always accurate. So it doesn't say you can't use those. But it says in certain situations, if you are using them, you have to make sure you have a human translator checking it. Why? Because those systems aren't great. So I'll give an example that we saw during the COVID pandemic. Virginia set up its website. So in English, once vaccines were ready, it explained how you could go get a vaccine and the importance of getting a vaccine and scheduling it. And it had an automated translation for Spanish. And the Spanish version was said a vaccine is not necessary. Well, that's not how it should have been translated. It should have explained how to get it. So that's just but one example. We had a lot of examples that we included in a complaint we filed with the Office for Civil Rights. So if a document or information relates to the rights, benefits, or meaningful access, if the accuracy is essential, which, if you're getting consent for a procedure in healthcare, you're explaining how to use a prescription drug or an inhaler, or if the document or materials contain complex technical or non-literal language. In these situations, if the communication is critical, a human translator is going to have to check that automated translation. There's also another provision, a little bit more specific, related to artificial intelligence as opposed to automated translation. That you can't have discrimination in the use of patient care decision support tools. Okay, technical term. What the heck does that mean? Well, sometimes providers are using automated intelligence to help make diagnoses, to determine the best course of treatment, et cetera. There's now a responsibility to make sure that those are free of discrimination. So, for example, another one we've seen is pulse oximeters. Unfortunately, are not often appropriate for people with darker skin. So people of color may have their pulse ox misread if they're using one of the systems because they were designed and built around white skin. So using something like that, or using other algorithms in healthcare to make decisions about who gets treatment or clinical standards of care, who gets access to a ventilator, which we saw during COVID and impacted significantly people with disabilities. Now there's a provision that explicitly says you have to ensure that those are free of discrimination. I want to also be clear that while this provision talks about patient care decision support tools, Section 1557 more broadly applies to algorithms in healthcare. So if you're talking about an eligibility system, someone's applying for Medicaid, it's not a patient care decision support tool, but it's still broadly under Section 1557, and you can't discriminate in how that eligibility system is making decisions about who's eligible or not. Okay, the effective dates of this new regulation, again, as I mentioned before, March 23rd, 2010, the day that President Obama signed the Affordable Care Act into law, Section 1557 became effective. It's a statute, it's in the law, it hasn't gone anywhere, it hasn't changed in 14 years. What's changed is sort of the interpretation as we move through different administrations. So with this new regulation, on July 5th of this year, most of it's going to become effective. There's a couple times because of new provisions or new applicability that the administration's giving these covered entities a bit more time to come into compliance. So if we look a little bit more clearly, for example, the requirement about having a Section 1557 coordinator, they're giving entities another 6 months to get those in place. And the same thing about providing a notice of non-discrimination. Also recognizing it may take covered entities time to develop policies and procedures, they're giving them a little bit more time, another 2 months after this effective date. So those are some of the general effective dates. I would be remiss if I didn't talk about what happens if you see discrimination happening. So just real briefly here. The Office for Civil Rights does have enforcement mechanisms. The rule itself talks about administrative procedures for how to file complaints, how complaints are going to be evaluated. When the Office for Civil Rights does come to a resolution of a complaint, it posts those on their website. So those can actually be good resources for folks to share with their employers or facilities are going to, or providers that they're seeing to, sort of show that enforcement is happening. Generally, enforcement is complaint driven, so individuals have to file complaints, but OCR can actually investigate on its own and sort of do a compliance review, and we've seen them do this sometimes in the past. The Department of Health and Human Services is going to look at complaints that govern programs within HHS. So if there's an employment issue, HHS is really not going to investigate that complaint. They may send that over to like the Equal Employment Opportunity Commission. But if there's discrimination that a patient is facing in healthcare, that's something that can be brought to the Office for Civil Rights. So finally, just in terms of filing complaints with the Office for Civil Rights, here's how to do this. It doesn't have to be the patient who faces discrimination or the individual. It can be an advocate, it can be an interpreter, it can be someone else in that facility. We've also found that it's we've been more successful sometimes if we identify a pattern of issues that are happening. So I mentioned this complaint we filed during COVID regarding limited English proficiency, and we found problems in 19 states. So we filed one complaint outlining these issues in 19 states, and then the Office for Civil Rights was able to investigate that and also put out some proactive guidance before the more recent unwinding of the continuous coverage requirements in the Medicaid program to say, just a reminder, here are some of your obligations. So with that, we've got a bunch of resources. I believe the PowerPoint will be sent out in advance. I can also make sure that these are posted into the chat for you all. And certainly I look forward to the conversation. And also here's my email, which I can also post into the chat with any more specific questions. So again, thanks so much to NCIHC for bringing us all together, and I will turn it back to Cindy at this point.
Mara, my head is spinning. There's so much in here that is so valuable for those of us who are working for language access, and that is so critical for hospital administrators in particular to know, that is, going to be applying to their institutions. Thank you so much for that overview. And I encourage all of us to go on the website of the National Health Law Program. Mara and her colleagues have published a document that kind of explains all of this in a way that may be easier than actually reading what's in the Federal Register, which is 81 pages long and is not the easiest thing to access. So, NHELP, I encourage you all, it's at www.healthlaw.org. They have resources that will allow you to study up on this. Thank you, Mara, so much. I'd like to go on now to Sean and say, okay, so one of the things that's being required is this appointment of a Section 1557 coordinator, thank goodness. So there'll be somebody who's actually responsible for bird dogging this through the hospital systems. And you have been one of these people. So Sean, can you tell us what is a Section 1557 coordinator. Why is this an important role? What does this person do? And what is, and also maybe you can tell us a little bit about the overlap between language assistance and also the accessibility services, as these are all coming together here. So Sean, I'm going to turn it over to you here.
All right. I was just giving the interpreters time to switch. Thank you guys for having me. It's such an honor to be on this panel with you guys. Having been in that role, I can tell you it's very much being like a point guard or a quarterback, if anyone's familiar with some sports here. But you take ownership and responsibility of this process. But that does not mean you do it by yourself. Oftentimes, you are basically doing it by yourself, but you are trying to loop in other people and get their feedback and get their support on different things. So other stakeholders within a healthcare organization would be risk management, patient experience, nursing, the physicians group. Those are just to name a few. Quality management as well. Those are all different groups that you want to have involved in this process. And then that coordinator would want to work with each of those and help them understand what the regulations have, and then how we apply it in those specific roles, because there are different ways to administer it. Basically, this person is also responsible for helping develop those policies and procedures. Institutions that I know of, many of them, when they had the original requirement for the coordinator, and then when it went away and now it's back again, a lot of them just never got rid of it in the first place because they saw the benefit of having someone in that position. Part of those reasons that you would have it is it helps you with patient satisfaction scores, it reduces medical costs, it has improved health outcomes. It helps with health equity, which is another thing that's becoming more and more prominent. I do know that the Joint Commission is starting to look more and more at that. They've had certifications now geared towards health equity and health outcomes, which is wonderful. I hope that we advance that more for social determinants of health is what I'm referring to. And then also helping understand that we're preventing cases from coming up where there's maybe operating on the wrong person or not even doing the right procedure because there was a misunderstanding that entire time. I can say, for example, when we've had physicians refer patients to our facilities, we've had start interpreting, and then when the anesthesiologist and another surgeon who might not have been their physician who referred them for the procedure starts to talk to them, you realize, oh, this person has no idea why they're here and that they're here for a procedure. And then you have to completely scrap that whole procedure or do brand new education. And that's an impact on funds because now you have had to reschedule everybody. That also impacts holding up all these other people who have to have procedures. So it really comes down to it does impact your bottom line. This person, going back to their responsibilities, develop, implement policies and procedures. They help manage the complaints for discrimination, make sure that they're being addressed. So the regulations will say that you need to have, I think, at least 3 years of documentation from when the grievance was resolved. So not from when it was filed, but from when it was resolved. So, you might want to just keep, 3 to 5 years worth of those grievances on hand. What you did, who you talked to, what was the nature of the grievance, who was the person or persons involved in that situation. I will say, having been involved in some of those processes, it's unfortunate. And a lot of it just comes down to maybe there were some microaggressions and that person just required more training to understand, maybe they did not intend it, but discrimination doesn't always have to be intentional. It can be an unintentional thing. And it's important that we recognize those biases that we may have. And then also the coordinator would monitor and reporting any necessary things. The person would also be responsible for helping people file those OCR complaints as well. So I have helped patients fill out those complaints. Also, with your state bodies may have different regulatory entities that you might have to report to as well. Such as if they're receiving state dollars, they might have their own set of regulations that you have to go and report to them as well. So being able to help fill those things out is beneficial as well. Now, when it comes to, it is a broad law, like Mara had talked about. So I just equate it as, if you're treating someone differently, then there's probably discrimination involved. And there's got to be a reason, like what's going on. And that could be a whole list of issues. So we're going from sexual orientation and gender identity all the way to language access. Now, a lot of organizations may have interpreter coordinators. Some organizations do give the Section 1557 coordinator position to them because there is a large language access component to it. And that's fine. What I would encourage healthcare systems to maybe view the coordinator role as more as like a committee chair instead of somebody who just does it all, and your committee should be different stakeholders, nursing, physicians, quality, patient experience, even human resources, that kind of thing. Having different people working together with the coordinator to help implement those things. Some facilities I heard had language access champions or Section 5057 champions. So they might have someone who oversees it for the entire enterprise, but they have different individuals in different locations that help them monitor and work on the compliance for that specific location, which I think is a wonderful implementation. But as far as each organization, how they can implement it for their organization, it's a case-by-case situation in that way. But you do have to have one person or persons designated as that coordinator.
Unmute myself here. Sean, I'm wondering, clearly this is something that somebody could do in the odd 20 minutes they might have free during the week, right? Ho, ho, ho. This is a huge piece of work. And I'm wondering if you have any sense of, even if this person is, the quarterback of a big team, where does it make sense for a hospital or clinic to position this person? What kind of, are we saying, wow, they should hire somebody new full-time just to do this? Are we saying that the coordinating activities could be added on to an already existing position? And if so, where does it make sense aside from language access? Is it just the language access coordinator is the logical person, or could it be someone else?
It depends. Our typical interpreter response, right? So I would say I would personally love if each organization had one person, like this is their only job. That would be fantastic because it's a big job, especially if you're doing it right. And even if you only have one hospital, it's a huge job. It's a lot of because you have to go through each and every program you offer. It's not just the physical entity. It's the programs you offer as well. So if you have a special program focusing on heart catheterizations, okay, well, what are we doing in that particular service line? You have to really think about it and break it down. So for me, I think it would be helpful to have one person who does it full time because it is such a big job. And being able to work with different entities within your organization would be wonderful. As far as where to place them, I have seen them in different parts, different departments in healthcare. I would say I've seen it most probably in patient experience or risk management is usually where I see them. When I was doing it before, I was actually in quality management, which was at first I thought was kind of odd because I used to be in patient experience and then I was moved over to quality management. But it kind of made sense because quality management is going through all those documentation already. And you're already working with those same groups of people on clinical measures. So why not just add the health equity measures as well. And it just kind of was a natural fit because we also had our joint commission person in that same department. So it was just kind of a natural fit for our organization. I wouldn't get too stuck on where to place them, though. I would just encourage everyone to get one as soon as possible. Don't wait till November for that requirement to become in effect.
Thank you so much. There's great advice. I hope all of you healthcare administrators out there are listening to this. And speaking of that, let's shift now to a healthcare administrator, Joanne. Can you tell us, in your point of view, from where you sit, how are these new regulations going to impact healthcare administration and the healthcare systems that they run? How much of this is new and it's going to make a big shift, or maybe not so much? Or and what would you recommend if for an institution as their very first step, trying to get people to start walking down this road?
Thank you so much, Cindy. And again, to echo Sean, I appreciate and I'm so grateful for the opportunity to be part of this conversation, and humbled by the knowledge and experience that is sharing the screen with me right now, to say the least. And to echo Sean as well, I think the bottom line is it depends. So to your first question of whether this is going to impact the organization and how is this going to impact administration, I think the reality is, depending on how deep the organization is already in value-based care, value-based purchasing, how sophisticated they are in their acknowledgement and interpreter services and support, it will impact on different levels. If you're very new and young in this kind of support journey, then this would be a significant lift. I hesitate to think that there are many organizations out there that already are not providing these services on some level, and who are not already doing it, maybe in pockets or throughout the organization in different ways. So I think it's really just a matter of pulling together what you currently have in place and identifying where you need to shore up some of those resources, clarify those resources, and really coordinate them better. So while this will have an impact, I should say as well, some of this does impact organizations depending on their location. So for example, Yuma Regional is a rural, very rural organization. We're a sole provider. We are in the southwestern corner of Arizona. We border Mexico and California. There is nothing between us on either side for 180 miles. So we're it for our community and for the community of our migrant population that crosses the border and comes to us either on a daily basis or to the county on a daily basis, or comes to us through the immigration process. So we are very restricted by the resources that we have within our community in order to provide resources that patients may need. We also have an extensive winter visitor population. So we surge during the year. For about half the year, we double to triple in size depending on the year. So it is a constant process of evaluating who's in the house and who's in our clinics and what their needs are. We also have an indigenous population. We have 2 tribes that are in our community that we are working very closely with Indian Health Services to support and to really build that bridge and overcome a lot of the healthcare trauma that's been experienced on a generational perspective for those patients. So that being said, I think for us, it's impacting us specifically in the way that we are understanding we need to have an investment into building our own. And that's happening on many levels for us as an organization and as a community. But we realizing that we have to invest in providing the support and the training and the resources. And in Arizona, you have to be level 2 certified as well. So from an ASL perspective. So the challenge, there is definitely a challenge in being able to access the services and the resources and the skill needed in order to best support the organization and the patients that are presenting in our community. I would say the first step, and certainly our first step, is identifying as an organization what's actually happening. Don't assume that nothing's happening, because there's no question that any organization delivering healthcare, no matter where you are, is providing some type of support. It's what we do. It's our reason and our purpose and our primary objective. So identifying what is happening and what you're currently providing, because there's a lot of different contracts, there's a lot of different relationships that require this on different levels. So if you're engaged in value-based care, on any level, value-based care requires health equity. It requires an understanding and documentation and providing services. If you're involved in value-based purchasing from the hospital perspective, then you're obviously being required. So that's got to be in place in some level. And then also just, there's cultural humility requirements and understanding. There's all kinds of different elements that are probably being addressed throughout the organization. And as is the case in our organization, just hadn't been brought together under one roof yet. So that was when I was brought on, that was part of my responsibility, was kind of, herding the cats and making sure that we are really addressing the needs of our patients in a unified and a comprehensive way. I think the other element to kind of mirror Sean's conversation about how to best position certainly the coordinator. I think most important is being able to have someone who is in a position to have access to the rest of the organization. We can't have this position live in a silo. And it's one of the reasons why experience has been, in the industry, has been breaking out from underneath quality and taking on a responsibility and a role in the organization independently. We know that when it's one part of one vertical's responsibility, it tends to not to be everybody's. So I think it's important to make sure that this person has access to the rest of the organization, both from a knowledge standpoint, so operationally, someone who's going to be embedded in lots of conversations and lots of meetings and lots of processes, but also someone who has the opportunity and the skill level to be able to connect. This needs to be seen as not just another thing that checks a box or another element that we're just, being tasked with doing. We really need to have someone in this role who can champion the values behind this. Because yes, value-based purchasing, health equity, social determinants of health, all of the things that we're being required to document and to monitor. The bottom line is that this really speaks to our fundamental purpose for human connection. And without that presence of human connection, we're not effective. We're certainly not as effective as we need to be or as we possibly could be. When a patient presents and they are given the opportunity not just to be seen, but to be heard and to be understood in the language or the format that they need to communicate, just even acknowledging and asking and our process of documenting but communicating that this is what this person needs, we are opening the door for that human connection. We are making that possibility three-dimensional instead of just a checkbox. And that's critical and essential for clinical outcomes. It's critical and essential for our performance in our HCAHPS, our CGCAHPS, our CAHPS for MIPS, our surveys, all of our online reputation, all of the things that are impacting the business element of healthcare today. But most importantly, we are providing and creating an environment and a moment where we are able to really, truly connect with that patient. And it doesn't have to be perfect. I think that's the other thing that we need to understand. It doesn't have to be perfect, but we need to be making that attempt and that effort and constantly be in a state of improving and perfecting and thinking outside the box. One of the things that we've had been challenged with, and it's been an extreme challenge for us, is finding live in-person ASL interpreters. We literally have no one in the city of Yuma, the county, who's available for our patients to be for a live interpreter, in-person ASL interpreter to be present for our patients. We have to request from a partnering agency. People have to, at best we can get someone to come from Phoenix. We have to do that 2 to 3 weeks in advance. I mean, it's a huge challenge for us. We have VRI, but that's sometimes not sufficient. So we have had to really think outside the box. One of the things that we've done is identifying a patient who's particularly challenged by the VRI that we've provided. We had our patient experience team partner with IT and the clinics and the hospital to be able to identify when he was coming in the event that we were not able to get a live interpreter, in-person interpreter. And we made sure to make very large screens available for him. And we worked ahead of time to position them so that he could see them both during his procedure and in his visits. And we have a tick system to know that when he's going to be presenting. And we have our advocate, one of our advocates at the clinic ready for him when he arrives and making sure that it's up and running. And it's, that's an intense process for a very busy healthcare system, but it's what this patient needs. And it's the right thing to do, which was one of our core values, is do the right thing. So, we are in the process of also exploring other ways to, and we have our Section 5057 coordinator position in process, and we're hiring. And our expectation is also to train someone, provide the training for that individual to become ASL certified in the state of level 2 certified in Arizona. So they will be available for in-person interpretation as well. And it's a very small portion of our patient population, but it's a critical portion of our patient population to be able to support. So it's a journey, and it's not going to be perfect every single, you have to start somewhere, and the goal is to continue to do the best we possibly can and meet their needs in any way needed.
So call out to all those ASL interpreters out there. Yuma's a lovely city, and y'all might want to relocate down there, take your friends, have a little community that you have work waiting for you at Yuma Regional Medical Center.
Yes.
Joanne, thank you so much, not only for your information and your insights into, how is this seen from an administrative point of view, but for your passion as well. I join with many of the comments in the chat where people are saying, can we just clone her and maybe graft her into every healthcare system in the country? It is for those who are working as interpreters and as advocates for this community, having somebody in administration like yourself who both understands these issues and can be a supporter is so critical. So, not only thank you for today, but thank you for being you at Yuma Regional. It's very exciting to hear all the things you all are doing.
I'm incredibly lucky, honored, and grateful for the opportunity to be able to do what I do. And Yuma Regional is an amazing organization with an incredible board and an incredible community. So it is my absolute honor and pleasure to support this amazing team and people who come through our doors.
So we've heard the legal arguments. We've heard Joanne saying there's a lot more than the legal arguments for the reasons to do this. We've had some great input from Sean about, what if Section 1557 coordinator, who is going to be the leader of the band here, needs to be doing and to look like. We've got about 35 more minutes. So at this point, I'd like to invite all of our panelists. Is there anything you'd like to comment on that you heard from any of the other panelists? And we're going to go look at our Q&A. We've got 50 questions in the Q&A. So definitely there's a lot of questions out there as well. But I'd first like to open it to any of you to add anything or comment on what you heard from the other panelists.
I think I would just add, oh, sorry, Sean, I totally just cut you off. But the only thing I would say is that I think the key to delivering this message and the acceptance in the organization and support is the human story. So being able to share the human impact behind this, yes, the legislation is critical and we're grateful for that, but to really understand that there are people behind this and how this has positively impacted care, but also the negative consequences that can happen when it's not delivered properly.
Sean.
I wanted to echo what Joanne was saying there. When she was talking, it reminded me of what a friend of mine who is deaf themselves, they were telling me how they appreciated how we had the services at the local hospital, and they just had to relay, like, every city that they're in, they have to look up which hospital actually provides language services and which ones don't. And I don't know about you, but when I travel, I'm not looking up the local healthcare system, because if something happens to me, I just assume you're going to take me to where I'm going to be taken care of, right? But when you're deaf, when you're limited English proficient, you have to think about those things. And to me, that's a huge barrier right there, that you have to anticipate what may happen to you. That's so stressful. And that's what people with disabilities go through all the time. There's that, they call, my friends who have visible disabilities, they call it the disability tax. That's what it is. It's a tax. They have to do so much more just to get basic services and needs. And we take those for granted. And so it's really important to really think about that and really bring that human element, because if I had to go and do all that stuff that they have to do, that would be very upsetting to me, because well, that's not fair. And it's not. That's why we have to have these regulations in place.
Okay.
I'll just say, as much as it is the law, and I'm a lawyer and I love the law, exactly what Sean and Joanne have said. This is about providing effective communication, patient-centered care, meeting individuals where they are. They shouldn't have to fit a mold to get care. We need to be providing the care that they need, when they need, in the form that they need, with the assistance that they need, no questions asked.
I'd also just like to add, one of the things Joanne said that really struck me is it reminded me that this is often a journey that hospitals and healthcare systems have to embark on little by little, that for some places, the changes that have to be made are huge. And as you can see, in places like Yuma, there aren't a lot of resources there to back them up. And so this may be a 3 to 5 year plan to get places where they need to be. But I'd like to get to some of the questions. Mara, we have a question from Genevieve Babecki. And by the way, if I mispronounce anybody's name, I beg your forgiveness up front. I will do my best and just beg ignorance and hope that you'll be patient with me. But Genevieve asks, do you think there will be an injunction, and to what degree? And maybe you can explain what that means as well. What's an injunction? And
rather than an injunction, will there be court cases challenging this regulation? Yes. There's already been one filed in Florida with I think a Catholic hospital, against some of the gender affirming care requirements and non-discrimination on the basis of pregnancy and related conditions, which includes abortion. We've seen challenges to the prior rules. Not as much on the language access piece as on some of the other pieces related to sex discrimination, but we'll continue to monitor it and see how it goes.
Okay. And Sarah Hessler asks, she writes, one of the new stipulations that will be challenging is the requirement to list qualified bilingual staff. Our organization does not expect other departments to call on qualified bilingual staff. And so for an organization with thousands of employees, this requirement would be a huge task. Any alternatives for compliance on this or suggestions? And that's to any of you there.
I'm not sure I have to go back about listing your qualified bilingual staff, but if you are going to use bi or multilingual staff to provide services directly in a non-English language, they must be qualified to do so. So this is not changing and all of a sudden saying Department A can call Department B because they've got a qualified staff. That's what your policies and procedures are for how you provide language services. This is really about a definition of who is qualified to provide those services. So like I said, there's a definition of a qualified interpreter for limited English proficient individual, qualified interpreter for an individual with a disability, qualified reader, qualified translator, qualified bi and multilingual staff. Let me briefly, if it's okay, Cindy, because I saw other questions, what does it mean to be qualified? And this is outlined in the definitions. Yes. So I'm just going to give you one of these. So a qualified interpreter for an individual with limited English proficiency means someone, and it's very similar, whether it's qualified interpreter for a person with disability or qualified translator, but let's do qualified interpreter for a person with LEP. You have to demonstrate proficiency in speaking and understanding both English and at least one other spoken language, or for a relay interpreter, 2 non-English languages. You have to interpret effectively, accurately, and impartially to and from the non-English language to English, using any necessary specialized medical vocabulary or terms without changes, omissions, additions, preserving the tone, the sentiment, the emotional level of the statement. And 3, you have to adhere to generally accepted interpreter ethics and principles, including client confidentiality. So this means an interpreter isn't necessarily a qualified translator. Someone who says they're bilingual might not be a qualified bilingual staff to provide services directly in a non-English language. So you have to make sure those who are providing these language services or communication services are qualified to do so, whether that's your staff interpreters, your contract interpreters, your video interpreter, whoever it is. So hopefully that also clarifies some of that. And I'll post this in the chat, but it's in the definition.
And Mara, can we assume, it gets very interesting when you consider that about 50% of interpreting at this point in time seems to be done remotely, and that many of those remote interpreters are working for large national companies or international companies, and many of them are outside the United States. But I'm assuming that these regulations are required of the hospital. So, I'm going to open this to Sean and Joanne as well. How can a hospital or clinic system that is contracting for remote interpreting really be sure that the interpreters that are providing services in their facilities through these third parties are qualified according to this definition? Anybody?
Yeah, I know that we haven't had a formal process in place for that evaluation, but we certainly have had complaints come back from patients and family members, or even staff who've called out, who may not have gone through our certification program, our internal interpreter LEP program, but who are fluent in the language, have called out the fact at times that was not sufficient, or what was communicated was not actually what was shared by the provider. So it's for us, when that happens, then we've contacted the vendor and had, some conversations about that, et cetera. But I think the important thing is to make sure that you have a high quality vendor. And we're in the process of switching, honestly, and in the process of moving to a different vendor who's comprehensive and very reputable and just an amazing partner and resource. So it's our responsibility to ensure that we do our due diligence and that we, are really vetting the quality of the services we're providing.
So vendors out there, take note that you have hospitals saying, "Oh, we're looking at this. We're being required to make sure our folks are qualified. We're going to start paying more attention to whether the interpreters really are." And so just this race to the bottom for the fee has got to go, and we need to be looking at quality. Sorry, I had to put that in there. Sean.
I agree. I'm always kind of surprised at how many healthcare systems do not have any. They don't even think of checking their vendors' capabilities. They just trust them at their word and what's in the contract. And it shocks me. And I say, well, what if this was a traveling nurse? What would you do? And they would say, oh, we would do this, 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 this. And I'm like, why aren't you doing that with the interpreters too? And they just look at me and I'm like, yeah, like, so what we did is I would do quarterly audits of each vendor we had. And I would randomly select a case and I would pick an interpreter and select that interpreter, reach out to that vendor and may say, okay, I want to see this person's resume. I want to see their credentials, their training, all the stuff. If they were on site, we also had to get their vaccination records, things like that. If any one of those things were not done correctly, that entity put us in non-compliance and that entity violated their contract, right? So it's a contractual issue, not to mention just a compliance issue. So, but I found when I would do those quarterly audits with these different vendors, they were more keen to make sure I had the appropriate level of care from these interpreters. They knew they could not just send me some random person. In fact, when they had a hard time finding someone, especially for like on-site, they would call me and say, okay, here's this person's name. I can send you the resume, but I promise you, I think they're going to be good. Like, because they knew if I saw that name on the invoice, somebody like, who is this interpreter? And I'm going to like look up the registry. Are they certified? Who are they? Did they just send some random person that says they can speak Spanish to me or, that kind of thing. So you can do quarterly audits. You do that with your staff. Human resources does it all the time. We should be doing the same with all of our vendors because the law puts the onus on the healthcare system and they view contractors as an extension of your system.
Right. And I will say the regulations don't get into minimum training requirements or certification requirements. It just says what's a qualified interpreter. So again, if the complaint is filed, it's going to be an evaluation of whether it was appropriate. But we all know that there are now ways to, have training. There's 2 national certification organizations for foreign language interpreters, and one of them also does sign language interpreters now for a minimum credential. Sorry, I'm one of those commissioners on the Certification Commission for Healthcare Interpreters.
Full disclosure.
Full disclosure, I put it on my slide. One other thing, I do want to apologize. Sandra, you asked the question about disclosure of the names of the bilingual staff. Yes, it is required in your policies and procedures to include the list of the qualified bilingual staff. I don't read that as meaning any department can call those folks to say, oh, I need to use them. I read it as more recognition that the covered entity has done this assessment, and these are the only folks who actually can provide services in a non-English language, but that's still subject to the parameters of what their job description is, what their responsibilities and roles are, when they're allowed to do it. So a little bit different, but you are right that there's a requirement to have a list of those. It's in a different, it's in the policies and procedures section of the rule, not in the definition section.
Thank you, Maura.
I would like to add to the qualified bilingual discussion. That's if you use them. If your organization chooses not to use bilingual staff, then you don't necessarily have to have a list and you just say, don't use them, right? That's just as an example. If you are using them, then you need to have a list. They just want you to hold you accountable to that. And they don't, when you say qualified bilingual staff, that does not mean an interpreter. We're talking about language concordant care, which is different. That means they are qualified to do their job in that language without the need of an interpreter. That's all that's talking about. Many people think of a qualified bilingual person, oh, that's an interpreter. It is not. There's a very clear delineation. So if they're a bilingual interpreter, if they're going to become an interpreter, then they have to fulfill the interpreting requirements of a qualified interpreter, which is very different. We tried to implement stuff like that. It did not work out because you know what? The interpreter has to be in the room for 2 straight hours, interpreting for all the therapies and all the physicians, while the nurse just has to come in and out. So are we going to really pull a nurse off the floors with other patients for 2 hours to interpret for all these people? That's not cost effective. So when you lay it out that way, then you're like, oh, we're not going to do the qualified bilingual thing because it's not cost effective. Language concordant care, I think, is important, and you should be able to assess those and provide that list.
Okay. Debbie Lesser sends in this question. She says, my hospital administrators say, this is nice, but the next administration might roll back these laws. So we're not going to spend money on things like appointing a 1557 coordinator. So what is the motivator for integrating changes aside from a potential slap on the wrist when there is the possibility with an election looming that there may be a change in administration?
So I will start by saying that, again, Section 1557, the statute in the Affordable Care Act, hasn't changed in 14 years. So again, I don't have a crystal ball to predict the future, wish I could. But I don't expect that the statute itself that prohibits discrimination is going to go away. We have seen different regulations. And different regulations may have different provisions. But again, if we look at what we should be providing to ensure effective communication and patient-centered care, while this may be a regulatory requirement now, it really should be happening as par for the course of how to make sure your ducks are in a row and you're ensuring this effective communication and you're ensuring that patients are getting the same access and quality of care as all patients in a facility. So yes, I'm a lawyer, and I've said this. I've been working on this law since it was being debated in Congress, trying to become the Affordable Care Act. And I think we still have a lot of arguments. We had them before this law was in place. We still have Title VI of the Civil Rights Act of 1964, that we should be not discriminating, and we should be providing effective communication and meaningful access to federally funded programs and activities.
Joanne, do you have any thoughts about, why else should a hospital move ahead with these, even though, there's a potential that there might be eventually some change in the regs if there were a change in administration?
Absolutely. And I was trying to unmute myself to jump in. Absolutely. I mean, a couple of different perspectives. One is the waste that happens in an organization when you do not have a centralized approach to coordinating services or coordinating resources. The reality is that no matter where you are, if you have a non-English speaking or a limited English speaking patient or a patient with a disability, the team that's caring for that patient is going to do what they need to do to take care of that patient. And if you don't have someone in the organization who's coordinating that process, and you don't have it, streamlined, and you don't have, one vendor who's coordinating it with you, or whatever the case may be, then you have waste happening, because you could have multiple contracts. We've all seen it. You have multiple contracts in different clinics and different centers and different hospitals across. So just from a waste perspective and a cost savings perspective, it makes sense to have someone coordinating that. But also the other implications outside of the 1557 coordinator position, there are so many other elements of care delivery and contracting that we're required to be providing this type of resource and these type of supports. So whether that person's title is upheld by legislation and a 1557 coordinator is responsible. And I don't mean to minimize it by putting air quotes. I'm saying, whether that's ultimately the decision that's made from a legislative perspective, this person will be a valuable and should be part of they'd be a valuable resource and a very significant cost savings investment, quite frankly. From licensing, from all of the different elements of time that goes into making sure that what you need in place with DMV or with JACO or whatever, your regulatory bodies are. It's not a nice to have. It's not a just in case. This is essential and critical.
Thank you. Kelly Grish asks, are there any considerations for people who can't read in terms of the notice for discrimination being provided? And she says, I know the MPRM, and I'm not sure what that means, has mentioned something about audio recordings.
Sure. The NPRM is Notice of Proposed Rulemaking. So that was the original proposal, and now we've got the final one. If you take a look at the rule again, it's under, part of it's under the definition section of auxiliary aids and services that have to be available to individuals with disabilities. This includes qualified interpreters, but also qualified readers, taped texts, audio recordings, Braille material and displays, screen reader software, magnification software, optical readers, etc. It's not supposed to be an exclusive list. So again, for people with disabilities who might not have the visual ability to read a notice or go on a website, there does have to be assistance to ensure non-discrimination for those individuals as well. There also is a second final rule that came out right after the 1557 one that updates regulations implementing Section 504 of the Rehabilitation Act, which prohibits discrimination against people with disabilities by entities receiving federal funds. It's the first update to those regulations in 47 years. In some ways, they parallel the Section 1557 regulations, and in some ways, they go beyond them. So that's another aspect as well.
Okay.
Sorry, for someone, Kelly just put it, for someone who's never learned to read, I would say, yes, they still should be providing assistance to ensure the meaningful access. And again, have text read to them or explained to them, or find another format, a video format, an audio format that would be helpful.
Joanna Ramos asks about the requirements for notification, the top 15 languages in the state. And so is this based on the top 15 languages spoken among people who report speaking a language other than English at home? Or does it go directly to the languages of people who report being limited English proficient? Because, as you know, we get all sorts of strange anomalies when we look at the, languages spoken by people at home, where we get, all of these taglines being written out in languages for people who are completely bilingual and being left out for the people who are like language number 16, but where there's a large number of LEP, a large percentage of the population is limited English proficient. Any thoughts about that? Mara, do you know, does the requirement in the regs say anything about what do they mean by top 15 languages?
I had it and I just lost it. Shoot.
Going on to the next question while Mara looks up.
Let me just point out, I did put in the chat, and I do hope people will see this, that there's currently work underway by the Office of Minority Health to develop a universal symbol for language access services. So again, even if you have a notice in 15 languages, you're not going to get everyone who's LEP. There's some studies that you hit about 93, 95%. But there's been some efforts by the National Health Law Program and the National Immigration Law Center, among others, to see if instead we could develop a universal symbol that would then be accompanied by a phone number. So this could very easily be on the first page of a notice. So if a notice is sometimes 13 pages long if you get it from a Medicaid agency or healthcare.gov. If you could put the symbol on the front, and if you get widespread adoption and widespread understanding by the LEP individuals, would take a lot of outreach and education. But that might be a more effective way of notifying people how to request language services. So right now there's an open comment period, and I posted a couple links in the webpage. One is just a petition you can sign to signal your support. Individuals are welcome to it. The second is an actual comment portal if you want to provide some more specific information. And so the notice says it has to be in the at least, so again, not at most, at least the 15 languages most commonly spoken by individuals with LEP of the relevant state or states that a covered entity operates. So again, you could go to 20, you could go to 25, but it's at least 15. And the Office for Civil Rights has in the past designated which are the top 15 in each state. I assume they'll probably update their lists as well.
That would be lovely. Then we all would be able to agree on what are the criteria. Super. We have an anonymous attendee who said, and I wanted to ask this too, can we get some clarification on the definition of an emergency? Because we're saying that we need to use qualified interpreters. We can't use family and friends, minors, unless it's an emergency, and the minor or the friend are the only people who speak this language that are available. But could you spell out for us, what does this mean? And particularly, what are the limitations on using minors to interpret? I have to say, I was very unhappy to see some recent research that was done by BCT Partners at the just surprisingly high number of providers who will admit that they're still using the kids to interpret for parents. So what do the regs tell us now?
So the regulations say you can't rely on an adult who's not qualified as an interpreter, except as a temporary measure while finding a qualified interpreter in an emergency involving an imminent threat to the safety or welfare of an individual or the public where there's no qualified interpreter. And I could keep going because it goes on another couple lines. Same thing. You can't rely on a minor except as a temporary measure while finding a qualified interpreter in an emergency involving an imminent threat. Is it clear enough? Y'all tell me. Some would say we write these regulations so they're clear as mud. Again, if a complaint is filed, it's a case-by-case situation. But I think in general, focusing again on we need to have qualified interpreters and what that means, knowing that a lot of times, if you might not be able to get a person in person, you could connect with a telephonic or video interpreting and get languages within a minute. I would say that the emergency involving an imminent threat shouldn't be lasting too long. But I am not giving legal advice, even though I'm a lawyer. Please don't take that today and bring it back to your institutions.
Oh, they're all going to say, Mara Udelman said.
That's all I need.
Okay, great. So let's see. Let's talk pharmacies. Charlotte Glass is asking, does this cover pharmacies? What kind of pharmacies are covered entities?
It should cover pharmacies that receive federal financial assistance. So if the pharmacy
if they take Medicaid,
if they're take Medicaid, Medicare, marketplace insurance, they should be covered.
Are there any pharmacies that don't?
There might be some. I can't promise you. I don't know every pharmacy yet. Same thing with the pharmacy benefit manager. Some of the ones that do mail order pharmacies or manage pharmacy networks, or what are they called? The lists, the preferred medications. I can't think of the name of the list. If they're getting federal funds directly, or they're contracting with an entity, like they're contracting with an insurer who receives federal funds, there's thank you formulary. They're subject to it too. Again, a lot of this, both Joanne and Sean said, it depends. That's their answer. That's usually my answer as a lawyer. A lot of this just depends on the circumstances. So if someone files a complaint, the Office for Civil Rights looks at the facts, makes a case-by-case analysis. But in general, if they're taking federal funds or they're otherwise subject to 1557, then yes. There's something in the chat about requirement to write translation in top 5 languages. That might be a state requirement or a Medicare requirement. I don't think it's a universal one. I could be wrong on this. I don't follow pharmacies as much, but I know there have been efforts to get more language access in pharmacies, and it's been challenging.
Okay, we have 5 more minutes and I'm scrolling down. We have all sorts of wonderful questions. Can you guys stay another 2 hours? No, huh? I was afraid of that. Let's talk about actually lodging a complaint and what to expect. First of all, in the past, I know we have had the Office for Civil Rights has been largely, well, it's probably not fair to say, but had suffered from a lack of funding for investigators. And as a result, even a complaint that goes to the Office for Civil Rights will be queued up and they might get to it eventually. So have you heard anything about whether there's any increase in staffing for OCR for doing investigations? And how long would a typical wait be for a complaint to be investigated and resolved?
I get to use my "it depends" again. Yes, OCR has staffing issues. We recognize that. We've been working with others at the federal level to try to get more funding for them, and it's just been a challenge. So that's why I think sometimes finding like a pattern of issues that are happening, maybe it's multiple issues in one hospital or multiple issues across providers in one state, or as I said, what we did with COVID across 19 states. I think sometimes bundling those and submitting one complaint can actually get attention. And if you're working on it or someone you know, you can help frame the complaint as opposed to one individual submitting it. So that's one way. Second, OCR has regional offices. They're willing to do training and outreach and education, so you can bring them in before complaints are filed to get assistance. Third, depending on your state, you may have other avenues to seek redress. Sometimes insurance commissioners or your Medicaid agency is interested and will respond. Your state attorney general, we've seen that in California and New York City. So it doesn't always have to be the Office for Civil Rights. I think it depends also, what is happening, and sometimes just getting the media involved. If there's significant harm that people are facing, that can result in change without having to file an OCR complaint. So I think there's a lot of levers that we can use. And I certainly encourage folks to, first have conversations and educate providers about their responsibilities. Despite the fact that we're all, up to our eyeballs in this, there are a lot of folks who don't even know this law exists or these regulations exist. So give them the benefit of the doubt, try to do some education, and then if that doesn't work, look at some other opportunities as well.
Thank you, Mara. We have just a couple minutes left, and so I'm going to ask each of the panelists for some final words. What you would like, the message you would like our listeners to go away with today. And I'd like to start with Sean, just because you're sitting right there to my left.
Sure. I would encourage everyone, I know this is a multidisciplinary group. I would encourage everyone that's in attendance or watching this later to consider what they can do. I know a lot of times we feel overwhelmed, but I just would encourage you to remember that little phrase about how do you eat an elephant? Just a bite at a time. What can you do in your area? Just start speaking out. Start going to your local healthcare organizations, talk to risk management, talk to legal, talk to patient experience. Just start talking to people if there's certain areas that are struggling with providing language access, and just start talking to them about this kind of thing. And you might be able to affect some successful change without things having to go to court or things having to result from serious harm to somebody. Be proactive, talk to your communities. I am constantly having to educate people who do not speak English that they do have a right to an interpreter, or they do have these rights afforded to them, and you're not going to be billed for it. And helping those in your communities that you're a part of to also understand they have those rights, I think would go a long way. And I think that's something that deaf people have been very successful at, is advocating for themselves. And I think if we could do the same with those that speak languages other than English, helping them understand that they have rights and they actually have power, that's a form of empowerment, is saying, hey, you can do this, right? And letting them go and act on it.
Wonderful advice. Thank you so much. Joanne, what would you say to our listeners today?
Well, I mean, I don't know that there's anything more to say after what Sean just shared. Beautifully and brilliantly said. I think about some of the members of our community who are challenged by fear and not having a voice because of their fear of the ramifications of speaking out. And some of them are very justified. So I would just add to that if they're not empowered to have a voice based on their current circumstances, be the voice for them, finding, a way. Also find your partners and find your allies in the organization. Find the people that are passionate about this, because they're most likely at the bedside. They're most likely the ones who are doing the work. Get them involved and keep the patient at the center of it. It's really, really hard to argue that someone needs this when you have that face and that story there to share. So
I love that. Thank you, Joanne. Let's remember what this is all about. It's all about the patient in the end. And Mara, final word to you.
I don't have a good one, but I think it's know the law, educate others, and help, as what Joanne said, get those stories and share it. It's very powerful when you can come in and say, this is what's required, and this is why we need it. It's both and. It's not either or. And help people understand their rights, file complaints if you're seeing violations, and get engaged, right? Within your facility that you're working, or facilities within your community, within your state. There's so much more we could do and should do, and we all need to work together to support each other and to make the continued advances. This is a great step forward, and only one that we need to take of many.
There you go, folks. You all have your marching instructions from these three great experts. The National Council on Interpreting in Healthcare thanks all three of you for your time this morning, your expertise. Very, very much appreciated. And thank you also to the over 300 participants that we had out there listening and putting in questions and posting to the chat today. You were very engaged. I wish we could have gotten to all of your questions. Maybe we can figure out what to do with them. And please remember that the National Council on Interpreting in Healthcare is a multidisciplinary, all volunteer nonprofit with the help of a couple of great contracted administrative supporters. But we do our work based on the volunteer support of all of our volunteers. Look us up at NCIHC.org. Join a committee. We only can do all of this because of the support and the work of our volunteers. So join us in this work. Thank you so much, everybody. And we'll see you back for our next On the Road webinar, whenever that is coming about. Thank you, everybody.